All right, good evening, everyone, and thank you for joining us for tonight's Woo You event. Our talk tonight is on ovarian cancer update for eye care professionals. With us tonight, we have Dr. Kamran Riaz, Dr. Cecilia Koetting, and Dr. Gottfried Konecny. Go to the next slide. Perfect. I'll be your host tonight. My name is Dr. Ariel Sorenzi. So I'd like to introduce our first speaker, Dr. Kamran Riaz. He is the Clinical Associate Professor and Director of Medical Student Research at the Dean McGee Eye Institute, University of Oklahoma. His clinical and surgical practices focus on the cornea, external disease, anterior segment, cataract, and refractive surgery. He has a regional referral base for managing a spectrum of conditions, focusing on managing complications from cataract surgery, secondary IOL surgery, and complex corneal surgery. He has authored over 80 peer-reviewed publications, 20 book chapters, and 100 plus presentations at the national and international ophthalmology level of meetings. He has been an invited surgical wet lab instructor and a visiting professor at numerous conferences and multiple academic institutions nationally and internationally. Holds several leadership positions, including serving on the ASCRS Young Eye Surgeon Clinical Committee as the chair of the BCSC Optics textbook and serving on the editorial board for several ophthalmology journals. He was also awarding I'm going to mess up how to spell that. How do you pronounce that?
I think if you don't mind interjecting, I think people know who I am, and I appreciate that. And let's just go on to the rest of the speakers. Thank you for having me. It's a pleasure and an honor.
Yeah, it was very impressive. Everybody knows who he is. Thank you, Dr. Riaz. So here are his financial disclosures.
And I'm going to go ahead and interrupt. It still hasn't gotten updated. That's okay. But it says hindsight. I'm just going to let you know it's University of Colorado School of Medicine.
Okay, awesome. And we've heard Dr. Cecilia Koetting speak, gosh, how many times on Movie now? Like 5, 6 times? Just a couple. So primary focus is on anterior segment and ocular surface disease, neurooptometry, and perioperative care. She's a fellow of the American Academy of Optometry, diplomate of the American Board of Optometry, serves on the AOA as an active member and both a local and state officer at AOA. She lectures locally, nationally, and internationally at conferences and has written multiple publications. Here are financial disclosures, all of which have been mitigated. And then last but not least, we have Dr. Konecny. He is a professor of medicine and obstetrics and gynecology, can't talk right now, in the divisions of hematology and oncology at the David Geffen School of Medicine at the University of California, Los Angeles. Had some training in Germany as well. We got to chat about that beforehand. So it has a lot of ongoing research interest, including the drug discovery and novel therapeutics for ovarian, uterine, and cervical cancer and clinical trial development. He is a member of the European Academy of Arts and Sciences, has served as ASCO Program Committee Chair and Co-Chair for the NCI Ovarian Cancer Clinical Trials Planning Group, and is a member of the NCCN Ovarian Cancer Consensus Panel. So today we get to hear from these 3 experts from 3 different perspectives on all things ovarian cancer and updates on that. So all of their financial relationships have been mitigated, and I'll stop talking and have you guys take it away from here.
Perfect. Thank you so much. I'm just going to do a little bit of setting the stage. And I agree, it is so interesting and fun to actually be here talking about this with doctors from other disciplines. I know I'm here actually to learn, not just to talk and speak and teach. So I'm really excited about this and to be able to be a part of this with 2 other phenomenal physicians. And the idea tonight is that we're going to really be talking about ovarian cancer. But I think it's important to, again, kind of set the stage. Let's talk about prevalence of cancer. And I think that arguably everybody who's here tonight would say that if they haven't personally gone through cancer one way or another, or one type or another, know somebody who has, right? So cancer touches all of us very intimately and personally in our lives. And the other thing to remember is our patients as well. And that's really what we're here to talk about tonight, is to talk about things that we need to think about specifically with ovarian cancer and certain treatments for our patients. And ovarian cancer, when we look at the estimated deaths, ovarian cancers is about 4% of patients a year. And that was in 2022. So it obviously is something that's continuously changing, but 1 in 3 people in the United States will actually be diagnosed with cancer in their lifetime. And, there's no easy way about it. And that's for sure. And I know my colleagues here are going to talk a lot about this. So we're going to kind of talk about the journey itself. And that's actually going to start with Dr. Konecny here. Sorry, I'm going to mess that up. And we're going to let him move into his portion of the chat right now. And I'll let you go ahead and take over the slides.
Thank you very much for the kind introduction. I am sharing my screen now. I hope you can see my slides. I will make them. I will do. Yes. Great. Well, it's a pleasure to be here, especially speaking in front of an audience of eye care providers. The only reason I'm invited to these educational meetings is because I've been working with various new drugs in the development of targeted therapies for ovarian cancer, and antibody drug conjugates have taken center stage, particularly one that will focus on Elahere or mirvetuximab soravtansine, which we have been working with for many years and have helped get to an approval for platinum-resistant ovarian cancer. And I'd like to share a little bit of background. You've already heard data on the incidence of ovarian cancer. It's not the most common, but it is still it's the 5th most common cause of cancer death and the 4th leading cause of cancer death in women aged 40 to 59, and 5th of those older than 60. Worldwide, a much higher incidence of 225 new cases per year. And most importantly, I think what the challenge in this disease is that there's only been minimal improvement in mortality over the last 20 to 30 years, where we've seen major changes in other diseases. So a lot of improvement is needed. Ovarian cancer, and I'm not going to bore you with too much pathology, but most of the cases are what we call serous, high-grade serous, which make up to 80 to 90%, as you can see, high grade. There are exceptions that are called low grade. That's a different entity, behaves different, treated differently, and then rare subtypes such as mucinous or clear cell. Most of those and the most patients that we'll be talking about are dealing with high-grade serous ovarian cancer. Now, the challenge with ovarian cancer is that there are no early warning signs. And that's why most patients get diagnosed with stage 3 or, in fact, stage 4 disease, where the disease is spread outside of the ovary and spread to either the omentum or to the spleen, but it is contained to the peritoneal cavity. So it doesn't have the tendency to form distant metastasis, but it really stays within the confinements of the peritoneal cavity. And you can see the challenge is then for a surgeon, a gynecologic oncologist, to resect this, and these are often very extensive surgeries to remove as much as visible of the visible disease that you can, which can include splenectomies, diaphragmatic stripping, bowel resections. And the goal is really to what we call optimally cytoreduce the patient after surgery so that there are only microscopic residual disease areas left. Now, a lot has changed in the surgical approach. This is a classical picture from Mayo Clinic, 1954, open surgery, hour-long procedures. This is the typical photo of an OR now. Robotic surgery, minimally invasive, all with the intent to reduce morbidity of surgery, to become minimally invasive, quicker recovery times. But the bottom line is still, the goal is to resect macroscopic, bulky disease because of the general diagnosis at a late stage, as there are no early warning signs. The bottom line is also the more you resect, the better the surgery is, the better the outcomes are. This is the survival curves for those that have either no residual disease, have 1 or less than 2 centimeter disease, or those where there is even more disease. And this is therefore the primary goal when diagnosed with ovarian cancer, to undergo successful surgery. The next step is then, because you can never remove all disease in the surgical through surgery, it is systemic therapy. There is either macroscopic or microscopic residual disease. And over the last 20 years, there is a standard of care chemotherapy regimen, which you may have all heard of, is a platinum plus paclitaxel or a taxane, that has shown to improve progression-free and overall survival when added to non-taxane containing regimens. There are multiple studies, and there are multiple modifications of this chemotherapy, either giving it intraperitoneally or giving it weekly, that have slightly improved, but the bottom line is still platinum taxane-based regimens. Then there have been improvements by adding bevacizumab. Bevacizumab is a VEGF monoclonal inhibiting antibody that has also led to an improvement in progression-free survival, albeit not survival. This is not a drug that causes any ocular symptoms, so you may not be that familiar with it. But with platinum taxane-based chemotherapy with bevacizumab as the main frontline therapy, we have now basically had success in some sense that we were able to push the progression-free survival up to about at median between 2 and 3 years. It's still not a major improvement. The other approach is that rather than doing upfront surgery, is that you would do chemotherapy prior to surgery, and that's called preoperative or neoadjuvant chemotherapy. And the reason is because you can downsize the bulky tumors. Surgery becomes less invasive, less morbid, recovery time is faster. Most importantly, outcomes are not better. It just decreases morbidity for patients. So in many cases, patients start out with preoperative chemotherapy. Next, this shows you a development of drugs in ovarian cancer. And you see that since 1990s, there were the last approvals of new drugs for platinum-resistant disease. That's the disease that recurs after this frontline chemotherapy within 6 months. And then nothing has happened over the years other than introduction of bevacizumab. And until recently, the approval of ADCs now, nothing really. And the problem with ovarian cancer is that it is initially responsive to chemotherapy. So you do get a good response, meaning patients go into complete remission and they stay in remission. However, in most cases that are diagnosed with advanced disease, a recurrence is predictable. And over time, the interval where the disease stays under control in remission gets shorter and shorter, and patients require repeated treatments with multiple lines of chemotherapy. And the big difference is when patients transition from a platinum-sensitive situation where platinum still control the disease to a platinum-resistant setting where it's an unmet need because patients are burdened with treatments that are less effective, they're burdened with a lot of toxicities, and therefore we really use the distinction between platinum-sensitive and platinum-resistant disease. And platinum-resistant disease has been a challenge for the last 30 years because patients have very little benefit, but they do suffer hair loss, they suffer side effects from chemotherapy, and therefore the development of an antibody drug conjugate, which delivers the chemotherapy payload in a directed fashion straight to those cells that express a surface marker that is differentially expressed, really has made a difference. And it's also moving us away from this classical one-size-fits-all approach that we use in oncology, where we are looking for biomarkers in ovarian cancer subsets, such as the folate receptor, and treating only those that have high folate receptor expression. Now, another major advantage, and I'll go through this quickly, in ovarian cancer is you may not hear a lot of talks about ovarian cancer, has been the development of PARP inhibitors. And the main basis for this is that we understood that ovarian cancer is not one type of a disease, but there are various germline mutations that can contribute to ovarian cancer. And this pie chart shows you that It's those that have a BRCA mutation or have BRCA-like mutations that are classified as being deficient in double-strand break repair. Those are patients that we know benefit outstandingly well from the addition of a PARP inhibitor, which is a drug that interferes with DNA repair and is particularly active in patients that have deficient double-strand break repair. This is reproduced across many studies and thousands of patients. There's no question these are 50% of the patients that benefit from this drug. So this has made a huge difference. But again, PARP inhibitors have no ocular toxicity. So you may not have encountered patients on PARP inhibitors. The big challenge is those that are not BRCA mutation carriers or that are not HRD deficient or BRCA-like, where these treatments do not benefit patients. Therefore, for me, it's been extremely rewarding in the clinic to work on the development of new ADCs as a new targeted therapy beyond PARP inhibitors. And the key development strategy, we're looking for a biomarker that is expressed on tumor cells only and absent or lacking in normal tissues with the intent to deliver chemotherapy in a more targeted fashion. And the receptors that are ideal for this are surface receptors such as HER2, or the folate receptor, or a number of other receptors where monoclonal antibodies can bind to and either be internalized or release the cytotoxic payload in the circumferential area of the cells. And again, this is a cartoon just to show you the molecular ratios. Monoclonal antibodies are large molecules. They're 150,000 kilodalton. Chemotherapy payloads are tiny molecules attached to the side of it. This is an antibody that then can get internalized into the cancer cell when binding to the surface receptor. And a good example is the folate receptor, which we'll be talking about a little more. And again, it's very similar to the Trojan horse. You're really incorporating a warrior into the cell where then the linker gets dissociates the payload, and then the chemotherapy payload can kill the cell inside the cell. This is a cartoon of the FDA-approved ADCs, and many of you have been seeing patients that were treated. The top are for hematologic malignancies. The lower line are solid tumors, including HER2, Nectin-4, TROP2, tissue factor, and lastly, the folate receptor with the recent approval of mirvetuximab soravtansine, which we'll be talking about. Now, what's unique about these drugs is they have less toxicity than systemic chemotherapy, which targets healthy and malignant cells. And however, they still have some toxicities, which we have to monitor. And clearly it is still chemotherapy, which we're giving. We're just giving it in a more directed fashion. And these could be hematologic. These could be gastrointestinal, albeit lower than standard chemotherapy. Of course, depending on the payload you give, you can have peripheral neuropathy, because a microtubulin inhibitor may cause peripheral neuropathy. And then for us of interest is this completely new block of toxicity, which is ocular toxicity, which we don't see with standard of care chemotherapy. And I want to basically just touch upon the topic as we have more qualified speakers following me. Is there are discussions about what's the toxicity or the reason for this unique toxicity of ocular side effects. And one is either it is on target or off target, and it could be the expression of the target on the cornea. It could also be non-related, off target, that the payload just gets internalized through what we call pinocytosis-driven toxicity, or it could be the payload dissociated from the actual antibody through a so-called bystander effect. Very little is known, and I'm keen to hear more from my colleagues later in this evening. This is just a busy summary slide showing you the FDA-approved ADCs, and it is an example that even though they're all ADCs, ocular toxicities do vary. Some have extremely high rates of ocular toxicity, like ADC targeting B-cell maturation antigen and multiple myeloma, and others have very little. If you look at trastuzumab deruxtecan, only about 11% have that. So we really don't know, is it the different payload? Is it the expression of the molecule? And I think much more has to be learned. And I do think that ophthalmic or eye care health providers need to learn and understand which antibody drug conjugate a patient is receiving, and what eye toxicities to expect with some being more severe and others being less likely. And what I think so fascinating is that I've really started to learn about the eye again after medical schools many years later, is that the cornea, which is really the focus of most of the eye toxicity, is really an area that can recycle within 2 weeks, is my understanding, and that really holding a drug can mitigate a lot of the side effects. But I just want to touch upon the topic that I'll give back to Dr. Riaz and Dr. Koetting. And I'm going to stop sharing my slides. This is just a brief overview of why I'm excited about ADCs, particularly in platinum-resistant ovarian cancer, and I'll stop sharing here.
Okay. Let me see if I can bring my slides here. Hopefully is that going through there? Okay.
Perfect.
Okay, well, Gottfried, thank you so much for that wonderful presentation. And thank you to all you and your colleagues who are certainly paving the way for treating these patients who really don't have any other way of getting better. And so kudos to you. I mean, we as eye care providers pat ourselves on the back on making patients 2020, but I mean, you guys are literally saving lives. So kudos to you and to your colleagues. So I'm here to kind of take the baton from what Gottfried has very nicely introduced to us about the patient's journey and some of the systemic events. And I'm going to hear instead talk about what we as eye care providers, as ophthalmologists and optometrists need to know about some of these adverse events that are associated with cancer therapies. So we already went through my disclosures, so I want to start off by first talking about a confession. You know, when I went into ophthalmology, it's because I didn't want to deal with patients dying. I hated cancer, and I thought I was just going to do LASIK and cataract surgery, and I don't have to deal with cancer ever again. And in recent years, with the emergence of ADCs, and those of us who particularly are working at academic centers with big cancer treatment centers nearby, we are seeing an uptick in these patients who are being treated with ADCs and have a significant number of ocular effects. I won't call them side effects or adverse effects, but just ocular effects. And you know, and Gottfried's probably smarter than most you know, non-eye care providers, but for many you know, oncologists and internal medicine folks, you know, they're very not as informed about the eye, and they really lean on us as eye care providers to be able to now direct them on what is a significant event and what is not a significant event. And so that's kind of where my interest, and I think many people's interest in this topic has come, is not because we wanted to treat a whole bunch of cancer patients, but because these patients are now coming to us, and more importantly, their cancer team are now coming to us as eye care providers, really leaning on us for advice. And sometimes we're like, well, yeah, this eye stuff we can treat as long as their eye's not going to perforate. But you know, these side effects that these patients are having is something that we're going to talk a little bit about today. So ADCs are a buzzword and a concept, I think, that all eye care providers we have to know about, because it is a growing space. It is exponentially growing. And we're going to see more and more of these patients, I think, that are going to present to us as eye care providers. There's 4 categories of ADCs that we should be knowing about. There's monoclonal ADCs. There's the interleukin targeted monoclonal antibodies. There's also the immune checkpoint inhibitors, and there's also the tyrosine kinase inhibitors. And there's over 100 ADC candidates. I'm sure Gottfried may know that the numbers may be more than that, at least but when I prepared these slides, that are in different stages of clinical research. But what do we as eye care providers really need to know? That ultimately ADCs, the 3 letters of ADCs, can remind us that there's 3 components to these ADCs. The first is that there's going to be a monoclonal antibody with an antigen specific for the marker, the cell surface marker on the tumor. So these are smart drugs that are going to bind to specific antigens that are expressed by the tumors. There's the linker of the ADC, and then the most important part that we really need to know about is the cytotoxic payload. That's the Trojan horse slide that Gottfried beautifully shared. And there's different types of these payloads here. And again, we don't have time to kind of go into all of them, but we see that there's these 5 main categories that interfere with different types or different pathways on the cell cycle. And what we're going to talk about today is really, going to be that number 2 category of the maytansinoids, of which DM4 or sorbistansine, mirvetuximab, which is used for ovarian cancer, is going to be relevant. But I thought it's important to kind of see the forest in addition to some of the trees that are there. So what is the concern? As again, we heard in the first slide by Dr. Konecny, our systemic colleagues, systemic medicine colleagues and oncologists love these medications because they have very little side effects. So they don't have the hair loss and the vomiting and the nausea and sort of that cachexia that is caused by some of the traditional chemotherapy medications. So because these specific antibodies are targeting antigen on the tumor cell, but there are some problems, there are some concerns, and specifically for what we as eye care providers need to know. One is that only a small percentage of the drug actually gets to the target. So a lot of the medication remains bound up in the serum with varying pharmacokinetics. And other tissues, particularly ocular tissues, can take up the drug, which cause adverse events in health. And so the features of these 3 components then determine how much of these unwanted or bystander toxicity effects that we can see. And these can range from mild toxicities like visual disturbances and blurred vision and dry eye, a little foreign body sensation, keratitis. Probably out of the 300 or so of you that are on this call right now, some of you probably have some of those mild toxicities going on right now. But severe toxicities, corneal ulceration and retinal vascular occlusion and optic neuritis, I mean, all those words sound scary, and that is a concern with some of these medications that we see. And this is why our oncology colleagues lean on us as eye care providers, that as much as they want to preserve life, they also want to preserve vision. And we don't want to have these patients be at a higher risk for having either severe visual loss or irreversible ocular toxicity. So some of the ADCs you may have heard about lately, tistotumab or Tivdak, which was for cervical cancer. This was causing severe dry eye and corneal ulcerations, which is why it drew a lot of attention. There were some corneal ulcerations and perforations that were reported by it. Enfortumab, which is Padcev, which is treated for bladder cancer. Again, dry eye. But there were some patients that did have, limbal stem cell deficiency, which is another reason why we may have heard about it. Trastuzumab, which is Enhertu or Cadicla. Again, I'm sorry for pronouncing these wrong, but these were because the HER2 receptors are expressed in corneal epithelium. These patients had ocular surface disease and cataract. And of course, the big one here, which I think is relevant for us because it has somewhat of a similar mechanism, is Blenrep. Even though it's used to treat multiple myeloma, these patients develop this granular epitheliopathy. And when we're going to talk about mirvetuximab and some of the, these cyst-like deposits is probably what most of us have called them, because they're not exactly cysts and not exactly deposits. But why do these happen is sort of the million-dollar question. Is it due to systemic delivery of the medication? Is it due to pinocytosis by these cells? I think this is still an area of great investigation. But Blenrep was removed from the market there in 2022, and it's something that we may not necessarily need to know about. But as far as traditional chemotherapy agents for ovarian cancer, which is what we're here to talk about tonight, platinum chemotherapy and taxanes, the good news and bad news for us as eye care providers. So bad news for non-eye care providers is that these have a significant number of significant systemic side effects. Good news for us as eye care providers, these are relatively low rates of ocular toxicities, which is probably why in years past, we didn't pay too much attention to these patients with ovarian cancer because they didn't have a whole lot of ocular side effects. Now, they did have a couple of ocular adverse events like vision changes, optic nerve changes, retinal nerve fiber layer hemorrhages, but by and large, these were few and far in between. And so we had the luxury of being able to sort of ignore this patient population and focus on treating eyeballs. But as I mentioned, with the emergence of these ADCs, these do have ocular side effects, and it's why we have to start paying attention to these types of medications. And so mirvetuximab is what we're going to be talking for the remainder of my time about. This is a new medication for ovarian cancer. Mirvetuximab is the first biomarker-directed agents showing anti-tumor activity in patients with folate receptor positive platinum-resistant ovarian cancer. That's a mouthful, but what does that mean in English? These are patients, these are women who otherwise have no other chance at survival because they have failed traditional therapy. They basically have a death sentence, as morbid as it is to say, and MIRV is one of these few agents that can actually prolong life, which is what makes our oncology colleagues so happy. But for us as eye care providers, this is why we have to actually care about it. Again, MIRV is an ADC, which has an antibody linker and has the maytansinoid DM4 payload. And in the phase 3 clinical studies, which evaluated MIRV in patients with these platinum-resistant cancers who had already failed 1 to 3 prior therapies. So again, these are women who have failed conventional therapy, have no other recourse, and now are turning to this particular medication. So what is MIRV? So we've talked about the 3 components of it, but the antimicrotubule payloads, these have been previously associated with resolvable and reversible. And that's why I kind of highlighted that term, ocular toxicity, because blurred vision, dry eye, keratopathy, we see this in our practice all the time. And we know that this is reversible. As long as the cornea basically hasn't perforated or we've got a blown out optic nerve, we know that most of these eye problems can be mitigated, reversed. And that's why it's important for us to be able to communicate that with our oncology colleagues. Again, the underlying mechanisms still are understood. It's thought to be an off-target effect. But in the Mirasol trial versus single agent chemotherapy, MIRV demonstrated a statistically significant and meaningful improvement in progression-free survival, the objective response rate, and the overall survival in these patients with predominantly low-grade neurosensory and GI adverse events. So again, they didn't have the hair loss and vomiting and nausea and all these other systemic side effects that we associate with traditional chemotherapy. So very briefly about the Mirasol study design. Again, 453 patients were treated with MIRV versus investigator's choice chemotherapy. The primary endpoint that this study was looking at was progression-free survival, and secondary endpoints were looking at objective response rate, overall survival, and these sorts of things here. Here we have a breakdown of that particular trial of the Mirasol trial. The ophthalmic safety monitoring criteria is very similar as we see with many other chemotherapy trials with monitoring visual acuity, slit lamp exam, et cetera, et cetera. But one of the big things, and I highlighted that in red so that we know that patients on MIRV do use prophylactic steroid drops 6 times a day, starting about 4 days before infusion. And that's an important thing to know because, we very rarely, I'm a corneal transplant surgeon. And so, we use 6 times a day after corneal transplants, but by and large, we don't prescribe 6 times a day topical steroids for routine patients. But this is something to kind of understand that these are patients who are using 6 times a day. And then up to 4 times a day, up to 1 week after the cycle, in addition to the usual song and dance of artificial tears. In the MIRV trial, they were not using brimonidine. We'll see with some of these other ADC trials, patients are using brimonidine, but this was not part of the Mirasol trial. We see here that good numbers across the board in terms of the MIRV versus the investigator choice chemotherapy. And we'll kind of jump to the results here. And the top line results is that the MIRV patient group had the objective response rate, which is statistically significantly higher than investigator choice chemotherapy. In other words, MIRV works. And so our oncology colleagues are very happy. And the bottom line finding is that this is the first treatment to demonstrate an overall survival benefit for patients with platinum-resistant ovarian cancer. But for us as eye care providers, why does MIRV cause problems on the ocular surface? We're still not sure exactly why, but there's several theories. One is that even though there's not many folate receptors on the ocular surface, again, this is specific for folate receptors expressed by tumor cells, it's likely that the drug gets into the ocular surface and tear film through some of the systemic vasculature. It's possible that the cleaver molecule is being dissolved by proteins in the tear film and releasing the payload onto the eye. And this attacks the limbal stem cell daughter cells, which are dividing, and this causes the surface toxicity. So when we look at the ocular adverse events, so look at the column here in blue with investigator choice chemotherapy, very few ocular side effects. These are all like ones and zeros over here. So this kind of looks like almost like a computer code over here. When we look at the MERV group, again, here where the arrow is pointing, significant number of ocular adverse events. So, but the good news is that those who did have ocular adverse events ranging from blurred vision, keratopathy, all of those that you see there, we don't see corneal perforations. We don't see optic neuritis or, retinal edema that you would see with things like MEK inhibitors. These are by and large things that in an anterior segment, optometry, dry eye type of practice, we see all the time, and we know that we can treat it appropriately with the armament of ocular surface therapies that we have. So thankfully, those with ocular adverse events in the MERV arm, about half of them had complete resolution of all events. 40% had partial resolution, and the remaining 7% who experienced adverse events had no documented improvement at time of the final database log, but the final grades were really grade 1 and grade 2 with no grade 3 or grade 4. So the big thing is that as we saw with things like Blenrep and Tivdak, no corneal ulcerations, no perforations or permanent ocular sequelae have been reported with mirvetuximab. But again, to highlight that, the median time of onset for these patients is sort of important to keep in mind, because when patients would present with things like blurred vision and dry eye, these patients are now being sent to the eye care provider to determine, hey, do we need to hold the next dose? Do we need to reduce the dose? And this is something that is very important because they're really relying on us to make that decision. So in the event that we do recommend either delaying or holding, the good news is that patients, even if the dose was delayed, patients still had good response to treatment. And even if the dose was held or reduced, they still demonstrated a benefit. But one of the things I want to try to convey is that unless we see that these are truly vision threatening, we don't have to stop these medications, because ultimately we got to decide, patient survival or dry eye and blurry vision and refractive changes, as we're going to soon see one of the unique things about MERV, because these can be managed. And we can't manage death, right? And that's why we have our oncology colleagues to help us out with that, with that. But the ocular service and refractive effects we can manage. So again, this is the recommended ophthalmic monitoring. I'll skip through that because we already talked about it. And I want to kind of share one of the big take home here is these microcyst-like epithelial changes here. It's hard to find pictures of these, and the few that I've seen, it's really hard to kind of capture these. Those of you who are familiar with Meesmann's dystrophy, unless you're a cornea specialist, you may not be familiar, but it kind of looks like that. You almost see these little fine microcysts that show best on retroillumination that appear in the cornea. And these can appear in patients with MERV anyway, and it doesn't happen after the first dose. It's usually after the third or fourth cycle that these patients have these findings on slit lamp exam. But how do they often present? And this is kind of what's really cool. It depends on where the cysts form. If the cysts form centrally, then we're going to have a myopic shift. It's almost like they have a post-hyperopic LASIK or hyperopic PRK type of ablation pattern. Whereas if the cysts appear peripherally, we get central flattening, almost like a post-myopic laser vision correction type of a pattern that ends up happening. Thankfully, these are resolvable with treatment with topical steroids, with tears, the tincture of time. And these patients, though, may need to have their refraction checked periodically or regularly while they continue the therapy, because they can go either hyperopic or they can go myopic because of these corneal changes. So again, these, in conclusion here, MERV demonstrates, statistically significant and clinically meaningful improvement in patients with this platinum-resistant ovarian cancer compared to investigator choice chemotherapy. The adverse events, which, as we talked about there, the dryness and especially the cyst-like changes, these are resolvable changes to the corneal epithelium that can be managed with either dose modifications if we truly feel the vision loss is real and significant, but more importantly with supportive care. And so recognizing these microcysts and refractive shifts and recognizing and conveying to the primary care team that we've characterized these ophthalmic findings as either severe or non-severe. And the vast majority of these are going to be non-severe, non-vision threatening that will resolve with the tincture of time and the song and dance of tears and topical steroids. But really, to try to limit unnecessary treatment discontinuations. In my experience working with our cancer colleagues, they often say, we'll stop the medication if you like, because we don't want them to have blurry vision. And when you kind of take a step back, you're like, wait a minute, we can deal with blurry vision and dry eye, but we don't want these patients to not get the therapy they need for life prolonging chemotherapy. So this highlights the importance, I think, of close collaboration between, eye care providers and oncology. And this hopefully serves as a nice segue to Dr. Koetting's presentation, which she's going to talk a little bit more about the interdisciplinary communication approach. But hopefully that's answered or provided some of the background we'll need for other discussions. So thank you for your time and attention. I'm going to stop sharing here and turn it over to Cecilia.
I think we should be good. Yeah, I think you didn't even have to stop share. Let me actually take over, which is impressive. So this is a phenomenal, getting a great understanding from Dr. Riaz and Konecny about why are we doing this? And it really comes down to, yes, there are side effects from it, and ocular side effects. But when we start talking about these patients and patients who are on this, it's these patients that are already past trying other things. This is not the patient that is at the beginning of their journey with cancer or are responding to traditional treatments. And that's the main concern here, right? And making sure that they can stay on that medication and understanding, how much, what's our threshold for stopping? Because I do see, as an ocular surface disease and cornea specialist in optometry, dealing only with disease, that's all I see is ocular surface damage. And I partner a lot with our oncology department in the university. And so there is a lot of patients that we see that are at different levels. And so we have to think about that. So patients,
Hey,
when
Dr.
we start,
Koetting,
yes.
switch your displays real quick. We're seeing the presenter mode.
You don't want to see my presenter mode? Thank you for letting me know. I
I'd love
appreciate
to
that.
see your notes.
How'd that go?
Thanks.
There we go. Is that better?
Yes, perfect.
All right, there we go. So discussing the diagnosis with the patients, a lot of times patients on our end don't understand why I'm asking questions about their cancer, the diagnosis, what they're on. And this is why, right? It's because there are so many different treatment types, and we need to know what, so that we understand what the underlying issue is. Now, patients on the drug that we're talking about tonight, really, there's a lot more interdisciplinary collaboration happening. I will have patients referred to me specifically saying, hey, we need a baseline. You need to watch them every time. We're going to talk about the actual timeline of how often we're seeing these patients. But understand that when you're asking about this, sometimes it can actually feel invasive because they're already seeing so many doctors, and we're asking these questions about a very personal thing that's going on, and they may not realize why. And with these patients as well, just try to make sure, can you put yourself in their shoes? Can you relate to the patient? Also understanding when is a good time to discuss things. But if we know that a patient is on medication that has a high risk for ocular involvement, we do need to be involved, right? We need to make sure that they understand that. So there are a lot of anterior segment and adnexal side effects that have come along with especially traditional chemotherapy. Talking about dry eye disease, blepharitis. There can be an overgrowth of Demodex in some of these cases. Meibomian gland damage is actually very common in a lot of chemotherapy treatments, and that can lead to other issues. Limbal stem cell deficiency, as Dr. Riaz was talking about, the medication that we're talking about tonight, there's some thoughts on it actually attaching to limbal stem cells, which we know actually lead to the proliferation of our epithelial cells. And that can then obviously start to cause some of these problems that we're going to talk about. Worst case scenario, a lot of times in these patients is truly looking at neurotrophic keratitis. And I think that that is something that we need to make sure we're evaluating. Now, in these patients with ovarian cancer that are going through this ADC treatment, again, we're looking at life and death a lot of times in these patients, and you just have to weigh the benefits versus the risks. And while we hold the eye dear to our hearts, it is not the only thing in consideration with these patients. So ocular adverse event grading with MIRV, there are different grades. And so this is how both the optometrists, ophthalmologists, their eye care professionals, as well as the oncologists are looking at this and grading it, which then gives us the idea of, are we going to pause treatment and hold? Are we going to proceed similar to what Dr. Riaz was talking about with the options on what to do? And the benefits versus the risks, right? So when we have a patient who has this and you are helping to co-manage these patients, this is something that you would essentially consult to say, okay, where are we at? Are we at grade 1, 2, 3, and 4? And communicate that to the oncologist who's treating to make sure that they're understanding where the patient is with their ocular adverse events. Management plan for patients who are on MIRV. There is a baseline ophthalmic exam prior to any treatment initiation. And then there are follow-up exams every other cycle, which is approximately 6 weeks or so for the first 8 cycles, which is approximately 6 months. And then post that, depends on what you're seeing, what the long-term effects as far as the eye is involved. If a patient unfortunately has developed more of the more long-term potential limbal stem cell deficiency and neurotrophic keratitis, they're going to be good friends with you. But, you know, if they've made it that far, hopefully that also means that their cancer is under control as well, right? The patients need to avoid use of contact lenses unless it's medically necessary. We could also talk about use of scleral lenses in these patients, which we do use heavily to mitigate ocular surface disease. So that does not necessarily mean that they would be contraindicated, but we have to think about it, right? Recommended use of preservative-free artificial tears at least 4 times a day or more during treatment. And then also ophthalmic topical corticosteroid is recommended as well, as Dr. Riaz was mentioning as well. So as far as the topical corticosteroids, they start the day before the infusion until 3 days after the infusion. And this is 1 drop 6 times a day. Now, when we talk about corticosteroids, personally, myself, if I'm going to use them in a patient who already has a high risk for OSD or dry eye, right, damage to the front surface, I'm going to use something that's less irritating. So I might use a loteprednol of specific variety, right, that has less BAK in there, that we also know can propitiate more damage or irritation to that front surface, or even considering using a compounded preservative-free dexamethasone may also be an option in these patients. Again, this needs to maybe be a discussion with the team itself. On days 5 through 8, the patient should be using 1 drop 4 times a day as far as the corticosteroids. With ophthalmic findings, the requiring dose modifications, Dr. Riaz also mentioned some of this, but the keratitis or keratopathy, depending on the level of that means we're going to monitor. So if it's just a little bit of SPK, we may just monitor. If we start getting to confluent SPK with epithelial defect or loss of vision, or starting to notice that we're getting a decrease in the vision of 3 lines or more, or worse than this, right? That's when we got to notify that oncologist. When we look at uveitis, this is also another thing. We're not talking about that particularly a lot tonight, right? We're talking more ocular surface, but that is also a risk factor with MIRV. And knowing that if we've got grade 1 to rare cell in the AC, that's a monitor. Beyond that, we do need to talk with the oncologist. And then again, in that position, it doesn't mean that they're going to stop treatment. We may need to just modify or monitor, and monitor more closely. And talking about that and the last couple minutes that we have here, making sure that we're looking at using anything we can to try to baby that front surface, whether that talks about our good daily eye hygiene with making sure that those meibomian glands are functioning well to get into the tear film, right? Heat masks, lid hygiene, nutraceuticals, managing any potential exposure at night if our patients happen to also be on a CPAP mask, making sure that we're really trying to keep that front surface from getting more damage other than just from the side effects of the medication. Other lid hygiene, we already talked about that, sorry. When we start to get to this level, this is a oncologist, right? This is not good. We need to be more aggressive in this. This is a severe limbal stem cell deficiency patient. This is someone who's actually having conjunctivalization of the cornea and will probably present with very significant decrease in vision. This is hopefully not where we're getting, right? This is the severe case. Even this is probably more of our mild limbal stem cell deficiency patients, but this is something we have to watch out for. And in this case, when we get to there, we need to remove any other things that may be adding to the problem. Discontinuing contact lens wear where it may not be fitting properly, switching topical medications, anything else that they may be using. And then also thinking about vitamin A ointment at night to help with goblet cell function, as well as protection of the front surface. Talking about we're already using topical steroids in these patients, but do we need to think about switching over to a preservative-free option? Don't forget our friends, our immunomodularies for the eye, our lifitegrast and our cyclosporin, as well as other things that we might be able to add in. We've got a whole treasure trove of different things that we can do to help to keep this from getting worse, to also keep our patients on a medication that is really important. Thankfully, as mentioned, neurotrophic keratitis, this is actually a picture of me going through chemo for colorectal cancer. So this is not really something that they have to worry about with the neuropathies in the fingers and the toes, right? But we do have to think about the front surface. And I think for me personally, it is really important to make sure that when I see patients that are going through any kind of chemotherapy, ADC, or otherwise, I am checking that corneal sensitivity. So I have a good idea in the back of my mind of what risk are we. If I start to see a corneal opening wound that's not healing, I need to think about this and I need to be more aggressive, and we need to treat these patients because, as Dr. Riaz mentioned and Dr. Konecny, there were not any ulcerations, but it doesn't mean that that couldn't happen. We still have to be on the edge of our chair and just monitor these patients very closely to make sure that we aren't missing something. So this is actually a patient of mine who had undergone chemotherapy. They were a stage 2 NK patient. They'd actually finished their treatment 8 months prior, but we do get neuropathies. See my picture of my hands, right? Eyes are an issue there too. What is the front surface? A bundle of nerves. So we have to just be aware. Just a couple other treatments you can think about: autologous serum tears for neurotrophic keratitis, also for severe dry eye. That is an option. PKP is also, as well as don't forget about our good friend Sinigerman for neurotrophic keratitis, as well as amniotic membranes. In these severe patients, this is not contraindicated. This may be something that could be very helpful for them to keep them under control. So in our last couple of moments here, I want to make sure we have time for any questions for our 2 other panelists here, because man, we got some great brains to pick here and I want to hear what they have to say for any of the questions. And big thing is just make sure that you're taking care of your patients, but also take care of yourself. I'm always a big proponent. If something's not right, get yourself checked.